Hello, everybody. My name is Noam Vanderwalde. I'm a radiation oncologist in the Department of Radiation Oncology at the West Cancer Center and Research Institute, and I've been tasked to give a 15-minute update in rectal cancer. Thank you for listening to this talk. So first off, I have no disclosures. So the treatment of rectal cancer has changed significantly, I would say, over the last 5 years. If not, you can probably say over the last 20 years. And we no longer have one standard of care. Historically, there were a couple of standard of cares for patients who had T3 or T4 disease or node-positive disease, and that was to give either chemoradiation, long-course chemoradiation first, followed by surgical resection, and then adjuvant chemotherapy, mostly done here in the US. Other countries, especially those in Europe and Canada, would give short course radiotherapy followed by only a 1 to 2 week delay, a surgical resection, and then adjuvant chemotherapy. And to give even a little bit more historical context, you can see that there have been kind of different eras in the treatment of rectal cancer, starting with when we would go straight to surgery and probably the pre-TME era, and then offer adjuvant therapy, to what many probably on this listening to this talk were used to treating in the what I call the neoadjuvant era, where we were using the previously discussed standards. And now, I think probably since around 2015 or so, we have now kind of entered what I'd like to call the either the total neoadjuvant therapy era, or what I prefer to actually call the personalized era. In the personalized era, I think what a lot of our trials are trying to do is to kind of turn the dials either up or down on these treatments, on the different modalities of treatment. Either giving long course radiation in those we feel appropriate versus short course who may not need as much radiation versus possibly no radiation. And similarly with systemic therapy, should we be trying to give less systemic therapy in certain patients or more systemic therapy, or moving the order of the systemic therapy? And of course with surgery as well, we're also kind of turning up and down the dials. And I'll give a little bit of an update on ASCO this year to kind of show you how we're doing that. So the major questions that we had in rectal cancer treatment kind of going into ASCO back in May of 2020 was what I would like to consider kind of the following questions. Number one, does moving chemotherapy to the neoadjuvant setting kind of improve outcomes? And also, what order should we be giving chemotherapy first, followed by chemoradiation or short course radiotherapy, or should we be giving the radiation therapy first and then follow that with consolidated chemotherapy prior to surgery? Which radiotherapy regimen should we be using, short course or long course? Can we de-escalate therapy? Does everybody need surgery, or does everybody need radiation? And also, are there some patients that we should be escalating treatments, meaning who needs more? So at this past year's ASCO, we started to answer some of these questions. So there were 3 major trials that were presented at ASCO this past year, including the Rapido trial, which asks the question, does TNT improve outcomes? The Prodige 23 trial, which also asks the same question, can TNT, giving the chemotherapy in the neoadjuvant setting help improve outcomes, but also looks at the question of maybe escalation. And then the Oprah trial, which is really a trial of can we avoid surgery in some patients? And then also begins to kind of get at the question of the order of the neoadjuvant therapy. So let's dive in. So the Rapido design, which hopefully many of you have now heard of, this study was a Dutch study, and it was specifically meant for patients who had kind of high risk, at least one high risk feature on MRI, meaning either they had T4 disease, N2 disease, lateral nodes that were positive, a threatened circumferential margin. And those patients were then randomized in a phase 3 design to receive chemoradiation upfront, followed by surgical resection, and then adjuvant chemotherapy, versus getting short course radiation therapy in the experimental arm, followed by neoadjuvant chemotherapy in a consolidative fashion, and then following that with surgery. And the results are the following. So you can see the experimental arm had a statistically significant improvement in path CR rate, and also had significant improvements in disease-related treatment failures and distant metastases, indicating that not only is this treatment helping locally, but also helping potentially with distant metastases, which is a major issue nowadays in these locally advanced rectal cancer patients. We don't yet have the information on overall survival in this study, but this is already a very good start. The next study was called the Prodige 23 study, also a European study, which again was a study looking at a total neoadjuvant approach versus the kind of standard of care, which I had mentioned historically was used before. So in one arm, again, this is a phase 3 large randomized trial looking at patients who had T3 or T4 disease or node positive disease. And they were randomized to the standard arm, which was chemoradiation therapy, followed by a slight delay to TME, and then adjuvant FOLFOX, versus giving neoadjuvant FOLFIRINOX for 6 cycles, followed by chemoradiation therapy, followed by delay to surgery, and then more adjuvant FOLFOX. And these are the findings. So you can see that the TNT arm, again, this is, and I want to point out, this is not a study specifically looking at the benefit of FOLFIRINOX. It's actually a study looking at the benefit of giving the chemotherapy in the neoadjuvant setting. So pathological findings showed a YPT0 or a complete response in the primary tumor that was a lot higher in the patients who got neoadjuvant chemotherapy. Disease-free survival was improved statistically. Metastases-free survival was also improved, statistically. And you can see when they were trying to kind of get at who really seemed to benefit from TNT, there were certain things that kind of did pan out on this univariate analysis, including patients who had higher stage seemed to have more of a benefit, and patients who with higher stage actually seemed to do a lot worse, stage 4 patients. But you can see here also that there seemed to be a little bit of a difference between patients who had middle rectum and upper rectum compared to those who had lower rectal cancers. And kind of higher risk patients seem to do better with TNT, kind of starting to indicate that there may be some patients that benefit from an escalated approach of using FOLFIRINOX. The next trial was the Oprah trial, and this trial has really already started to change some of our standards, and many patients are now asking about this approach. In this trial, so this is a little bit different than the previous trials, as this is not a phase 3 trial, rather this was a phase 2 trial. It was randomized, but both arms were not, the study was not designed to compare the 2 arms. Rather, it was a pick the winner design and compared to a historical control. Now in this study, patients with either stage 2 or 3 rectal cancer were randomized to receive consolidative chemotherapy, meaning they received chemoradiation therapy first, followed by FOLFOX or CAPOX, versus getting induction chemotherapy, meaning starting with chemotherapy first and then getting chemoradiation therapy afterwards. Then about 6 weeks after their last treatment, whether that was chemoradiation or chemotherapy, they were then restaged with MRIs, endoscopy, and digital rectal exams. If they did not have a clinical response or clinical complete response, they were taken to surgery. And if they did have a clinical complete response, they were watched and so did not have an operation. And again, both were meant to be compared to historical controls. Now, these are the results from ASCO. And as you can see, both arms did actually quite well in terms of disease-free survival and distant metastases-free survival, and were very well compared to historical controls, with both arms in the 77-78% range of disease-free survival, and the 80%, 82 to 84% range for distant metastases-free survival. But there was a slight difference. Again, the design of the study was not meant to compare the 2 groups, but there was a little bit of a difference in those who were able to actually get to watchful waiting, who did not need surgery. Now, as you can see, the patients who were consolidated seemed to have a better ability to be able to do TME-free treatment, versus those who had induction, meaning starting with chemotherapy first, were less likely to be able to have a TME. Now, in asking the PIs of this study why they thought this was, they felt that it could possibly be due to the timing. they have to evaluate these patients for complete response at some point in the study, at some point during their treatment. And in the patients who got chemoradiation therapy first, there's a lot longer of a delay, and you have more of a chance to be able to see that complete response, rather than if you start with chemotherapy and do chemoradiation second. And we know from previous trials that there is kind of a time period that's kind of the sweet spot for evaluating these patients' response to chemoradiation and chemotherapy. So it is not totally clear that starting with chemoradiation therapy should be a standard, but there has been at least one other study that is hinting at that as well. This was a German trial, also a phase 2 study, also a study in which these arms were not meant to be compared. Rather, these are both pick the winner designs, and similar design to before, where patients in group A had induction chemotherapy with FOLFOX, though they only got 3 cycles. They then had a rest period, then got chemoradiation therapy, then a longer rest period, and then were taken to surgery, versus in group B, where the patients got received the chemoradiation therapy first, had a little bit of a longer rest period, and then got 3 cycles of chemotherapy, followed by another rest period, and then surgery. Now, in this study also, the induction arm actually had a lower pathological complete response rate. Now, these p-values are not p-values meant to compare to each other. Rather, these are p-values compared to the historical control. They designed the study to be able to get about a 25% pass-CR rate, and the induction arm did not receive anywhere near that, possibly because they weren't using as many cycles of chemotherapy as we typically are nowadays, with either 6 to 8 cycles preoperatively. But they only had about a 17% PCR rate in the induction arm, and the consolidation arm had 25%. Now, does that mean that we should be starting with chemoradiation therapy in all patients? No, I don't believe that. I think that there are some times that we should be starting with chemoradiation and other times that we should be starting with chemotherapy. And there have been several studies that have suggested actually the earlier you start the chemotherapy, possibly the better in preventing distant micrometastases. And so these two studies alone, these 2 phase 2 studies alone, do not make me want to necessarily start with chemoradiation, though they are hinting at you may get a better pass-CR response rate if the longer period you have between the chemoradiation and the surgery. So at this past year's ASCO, there definitely were some questions answered. So the first question, does moving chemotherapy to the neoadjuvant setting help improve outcomes? I think we can definitively say yes. Now, we're still waiting on the overall survival of these trials, but distant metastases-free survival and disease-free survival are important endpoints in rectal cancer, and these were both improved in the 2 studies that we looked at ASCO, showing that really moving the chemotherapy to the neoadjuvant setting should be kind of the new standard of care. Now, what order do we get this in? I don't really believe that this was answered yet, but there are kind of hints that maybe starting with chemoradiation may be better in some situations, but I don't think that has been definitively answered. Which radiotherapy regimen? Short course versus long course. I showed you 2 studies, the Rapido trial and the Prodige 23 trial that used different approaches in their experimental arms. This question has also not been answered in at least at ASCO. And there certainly are some patients that I would prefer to do short course in. Those are usually patients that have either upper rectal cancers or cancers that are far enough away from the internal sphincter, so that kind of patients that we know will be able to do an LAR in. That being said, we should not be using short course in patients that we're trying to avoid surgery, and there's just no data for use of short course radiotherapy in that patient population. The other question is, can we de-escalate? And with the Oprah trial, I think we kind of answered yes. In some patients, it does appear that we can begin to de-escalate de-escalate treatment in these rectal cancer patients. So the question is, does everyone need surgery? At least so far, again, we still need the survival data from Oprah, but so far it appears that no, not everybody needs surgery. But that is something that we have to figure out kind of along their treatment paths to see how they were responding to the chemo and chemoradiation. The question is, does everyone still need radiation? That trial is still awaiting results. That's the Prospect trial, which hopefully we'll have some results for within the next year or 2. And then the other question, do we need to escalate therapy in some. Does FOLFIRINOX work better than FOLFOX? That was not answered. Again, the trial was not designed to answer that question, the Prodige 23 trial, rather it was designed to answer the question of ENT. And so I would say, no, we don't know the answer of whether some patients need more chemotherapy or more radiation than others. And the question of who needs more is still out there. And there are some trials that are potentially going to answer this question in the future. So in the long run, there are still plenty of questions we need to answer for patients who have rectal cancer. And hopefully, as we continue to design studies and to put patients on these trials, we'll learn more as we continue to treat patients, hopefully with a personalized approach. Thank you very much.